Good afternoon. Thank you everyone for joining today's webinar on newborn screening timeliness. I'm happy to welcome Sarah Weil. Sarah is a nurse practitioner at the Children's National Health System in the Division of Genetics and Metabolism in Washington, D.C. Sarah is also a member of the NIMAC Newborn Screening Work Group. For today's webinar, you will all be in listen-only mode and not be able to ask Sarah questions while she's speaking. What we ask you to do is raise your hand or type your questions into the chat box. When Sarah is done with her presentation, there will be an opportunity for you to ask her questions, either through the hand raising or through the question box. If we do not get to all of the questions during today's webinar, we will follow up with you if you ask a question in the question box after. Okay, welcome Sarah, you can go ahead and get started.
Hello, and thank you so much for the opportunity to talk to the group today about newborn screening. I've been tasked with doing a primer on newborn screening and timeliness related to newborn screening. So just a quick introduction to what I do. I am a nurse practitioner, as Beth said, in the Division of Genetics and Metabolism here at the Children's Hospital in DC. And my official title is actually Newborn Screening Program Director. I'm responsible for the follow-up of abnormal metabolic screens in the DC metro region. So that includes the district, Northern Virginia, and sort of Southern and Eastern Maryland. So I've had the opportunity to work in a couple of different state programs within our region, as well as on the clinical side of things, particularly with relation to the metabolic disorders. So I'm going to be talking a little bit about what newborn screening is, giving some case examples about why timeliness is so important, and just talking about how the system came to be in its current formation, with, I think, a lot more detail to come on some aspects of this in future webinars with some other excellent speakers in the coming weeks. Okay, so I went a little too far. So what is newborn screening? This is a question that actually I get a lot, and also how long have we been doing it? So this is a picture from maybe the teenage years of newborn screening. It's actually a picture of me watching my little sister who had her newborn screen done in 1990, because screening has been happening for a really long time. It's actually been happening since the 60s. It's been changing and growing, and the structure in which we do this screening and follow-up has changed, but it's been around for a very long time. And I wanted to start off with a case. All the cases in this presentation are real cases of children that we've seen here at Children's National, and that I think illustrate a couple of points that I want to emphasize around newborn screening timeliness. So we'll start with Logan, who was just a 7-day-old at his primary care provider's office, 1 week well child check. And this is a nurse practitioner. It was a Friday of a holiday weekend, which is often the case with newborn screen issues, but that's just something to keep in mind as we go through it. So Logan's history, past medical history, was pretty unremarkable. He was a term baby, born at almost 3 kilograms, exclusively breastfeeding, and had gone home on day of life 3. And as I said, he was in the office. But before the primary care provider even walked into the room, the medical assistant said that the baby was pretty much back at birth weight, had completed a 20-minute feed in the room, breastfeed, and that the parents, who were Spanish speaking, described him as very alert and healthy. They didn't have any concerns. And so the question I always like to pose to especially the providers in the audience is, would you check on Logan's newborn screen results? So of course, the answer to this really depends on where you're practicing, the state you're practicing in, but it's something that I don't know if everybody always thinks about. If you are in a place, practicing in a place where you could get access to a newborn screen at the 1 week well child check, I absolutely encourage you to always do that. But if you're in a place where that's not always standard of care, or it's difficult to get normal newborn screens perhaps, something to consider when you see a 1 week old is to be checking that fax machine and that mailbox for any male that might have to do with this child's screen, and try to find it if you can. In Logan's case, newborn screen had actually arrived via regular mail, and this is just a standard Virginia abnormal screen. I think if you've never seen one of these before, it can be a little overwhelming. It's just a lot of information to receive, and I'd like to sort of orient everyone to what the abnormal newborn screens look like. So I think most people can gauge the abnormal, so that's there with the red arrow. This is a maple syrup urine disease screen, which was above normal limits at 313, normal being less than 222. Sometimes this is where people stop looking and then just sort of start to freak out. But I want to also draw your attention to two other points on this screen in particular. First of all, this bottom red arrow actually indicates what the lab recommended for this child. So in Logan's case, repeat the blood spot and send it immediately. But another place I want to draw your attention, and this is kind of whited out for patient privacy reasons, but here at the top, the birth date, the collection date, and time. Keep in mind that newborn screening should be done between 24 and 48 hours, depending on your state. 24 hours is really what's required to have enough buildup of the intoxicating metabolites to pick them up on a newborn screen. And if a child has an intoxicating illness, you would presume that whatever abnormality they have is going to increase over time and hour by hour. So a screen collected at 24 hours is perfectly appropriate, but just keep in mind that an abnormal level at 24 hours is sometimes more concerning than a value at 48 hours, when you would expect that intoxicating metabolites have had enough time to build to higher levels. So in his case, this is a collection of 25 hours of life, so just over that standard amount of time. And it also comes with a very nice letter that explains the abnormality and the recommendations and gives some contact information on who to contact with questions. So the question, of course, now is what do you do next with this child? And the answer is really to remember your physical exam or your clinical evaluation of the child. So I always encourage people to interpret newborn screen results in the context of how the child actually looks ideally in front of you. And that is different than parent report because, as many of us know, parent report, while important, is not always the best way to kind of ascertain if a child is doing really well or not. So always trying to take a look at these children with your own eyes to do a complete physical exam, I would highly encourage. In this case, Logan did have his physical exam done, because as I said, he was in the office. The exam was essentially normal with one exception, and I'll highlight it for you here. The odor of pancakes or maple syrup was noted in the diaper. So in this case, remember, this is a Friday of a holiday weekend, and the primary care's office was told just to repeat the screen. But in this case, based on that clinical finding, the nurse practitioner actually contacted our office, contacted me directly and explained the situation. So I immediately recommended that the baby come to Children's urgently. And by the time the child even arrived, was already showing signs of worsening lethargy, was fencing and not eating. So we got plasma amino acids, quick turnaround time, and leucine was 2100, allo-isoleucine was 165. All the branch chains were very high, and this child was diagnosed with maple syrup urine disease. So basically, even minute by minute, was developing worsening signs of deepening encephalopathy, and was dialyzed in our NICU, spent 10 days with us, and is now actually a post-transplant little baby who's doing very well, developmentally normal. So the purpose of this case is just to highlight that while these diseases can be rare, there is a purpose for this screening that is life-saving. The primary care provider in this case probably saved this child's brain and life by responding quickly to an abnormal newborn screen, and that's really why we do this testing, because we can save babies' lives. So just something to keep in mind. I know it seems like it's rare, and it is, but when it's done right, it's an amazing public health program. And a little bit just about newborn screen, some background, since I am, as I said, doing the primer for this series. The terminology, to highlight some points that are important to me, you can call a newborn screen, or a newborn metabolic screen, or an expanded newborn screen, but please don't ever call it a PKU test. This is not correct. We screen for many more disorders than PKU, and while it seems kind of like a harmless terminology, it causes a huge amount of confusion. I can't tell you how many families I've seen who have heard from their pediatrician or their birth hospital that their child had an abnormal PKU test and have spent the entire night up researching PKU on the internet. And what it really was is a glycemia screen or something else, and they are very upset because they were very confused. It can even be confusing for other providers to call it that. So if you learn nothing else from this webinar but never to call it the PKU test, I'll be very, very satisfied with this process. And to go over the process a little bit, because I think it can be kind of confusing, all the stakeholders and how they all fit in together in this process. The steps are here, and I'll go through them in a little more detail, but just wanted to highlight who's kind of playing a part and what parts here. So the birth hospital is generally, or birth center is generally responsible for collecting the blood spot and then transporting it to where it needs to go. And that's typically going to be a laboratory, typically a state laboratory, although there are commercial laboratories and states do work together at times. They will process and test the dried blood spots and then report the results, whatever those may be, out. So when you're talking about reporting results, it definitely differentiates between abnormal results and normal results. But in general, results get reported to a follow-up program, and the follow-up program is responsible for communicating those results to either the pediatrician, the family, and or the metabolic or other specialist. So the specialist and or the primary care provider come in at that point when it's communicating those results from the state laboratories testing. And then data collection, I always like to put in a plug that if we don't collect data on what we're doing, it's really hard to improve our processes or figure out if what we're doing is working or not. So we all have a role in data collection. So when people think about newborn screening, I think a lot of them just think about this visual, which is the blood spot from the baby's heel. You put it on the card and then people send it in the mail, and I think maybe don't know what happens after that. But this is an important piece, obviously, is the blood spot collection. And something to keep in mind is that birth centers are responsible for doing this testing, as well as the birth hospitals, and that sometimes the primary care providers will be expected to do this blood spot testing as well in cases of abnormals or potentially in two screen states. We do have a two-screen state in our region. Maryland does one screen at 24 to 48 hours and one screen at 2 weeks of age. So the primary care providers there are responsible for that 2-week screen. When we talk about timeliness, this is a huge piece, is the transport and processing. So whether birth hospitals or pediatricians use a regular mail service to send blood spots versus a dedicated courier is going to have a huge impact on, just does it take 1 day or does it take 4 days for a sample to be received by the lab and actually start testing? And then once it gets there, what are the hours that the lab and the follow program is going to be open? So are they open on holidays? Are they open on weekends? This is important information to kind of know about your region because it has a huge impact on how quickly we get these newborn screen reports completed. And then at the lab, there's various testing that occurs, tandem mass spectrometry being responsible for the most conditions, but there are other methods of testing, and I know that there's going to be another webinar on testing in particular, but I just wanted to put up a little nod to it. And then, as I said, reporting of results goes from the follow-up program to the primary care provider, and in the cases of abnormal, possibly to the specialist. So the communication of these results by the follow-up programs is a particular interest of mine, being the person that often receives these follow-up reports. And what we found is that these state programs, which are typically going to be responsible for the newborn screening follow-up reports, there's a great deal of variability, and it depends on quite a few factors. First of all, being, of course, normal versus abnormal. How are normal reports generated by whatever state you practice in or whatever state you work with versus the abnormal reports. And then within the abnormals, whether these results are critical or what would be considered non-critical. And this could be disease-specific. Some diseases are considered critical versus non-critical. It could also be analyte specific or level specific. So, in the case of Logan with that maple syrup urine disease screen, he was considered non-critical abnormal. His leucine level was high, but not in the critical range. So if it had been in the critical range, it would have been a slightly different follow-up procedure in the follow-up program's estimation. So, and also, if his screen had been collected even a few hours later, his leucine may have reached a critical range, but in his case, it was still a non-critical range. And this is actually, this map here is a graphic I created for a paper in molecular genetics and metabolism back in 2013, along with my medical student I was working with, Sneha Jain, where she actually helped me survey the state programs informally, really, but to kind of try to figure out how states or jurisdictions were actually taking newborn screen results and communicating them with primary care providers and specialist providers. And as you can see, there's a great deal of variability across the country. So some states, the follow-up program will speak only directly with primary care providers, and then those providers are responsible for contacting specialists. Some states will, those are the states in red, some states will contact primary care providers and specialists together, and those are the states in purple, and then the rest of them sort of distinguish between what they would consider non-critical and critical, and that varies by state. So there can be a lot of variability here. But when contacting families, this is sort of the most delicate part of the process, in my opinion. So when you're talking to families, they just had a baby, they, in some cases, just got home from the hospital and are, resting, feeling good, but probably overwhelmed. And then they get a call from somebody that their child who had a test they may not even be totally familiar with, and it's abnormal. So some points to consider when you are contacting families, not that this is even necessarily a timeliness thing, I just think it's an important consideration for anybody who's going to be making these calls. Whenever you can, work with the state programs and the specialists to contact families if you're the one that they're familiar with. So hearing from somebody they've at least heard of before decreases anxiety a great deal compared with only hearing from a state Department of Health or a genetics department or an endocrine department. So whenever possible, being the recognized provider and contacting these families is really helpful for their anxiety. Another terminology point, abnormal versus positive, neither is incorrect, but I tend to use the word abnormal whenever possible because I think positive has a different implication for families. This is a screening test, it's not a diagnostic test, and so, it's not necessarily a diagnosis of anything. So when you just say abnormal, I think that makes that a little more clear. I also always highlight that we are screening for things for which there is an available treatment and an effective treatment. And that is why these disorders are screened in every baby, and we will do some kind of intervention to help their child if it is a true positive. And always share resources. It's a Google age. I don't know any family who doesn't hear about an abnormal screen, doesn't go immediately to the internet. So if you just give them a disease name and hang up the phone, they're going to go off into doing who knows what. So I always encourage families to check out Baby's First Test, but whatever your preferred resource is, I would encourage you to share with families because they will find it. And then when it's confirmatory testing and treatment, there are multiple specialties involved in the follow-up of abnormal newborn screens. So, it's growing all the time as well. So more specialties are even becoming involved. But it's not always genetic. And then reporting diagnosis back to the state and data collection, as I said, are invaluable for making sure these processes are going as smoothly as possible. So what are we actually screening for is a very good question people often ask. And every state's program is a little bit different, but as a resource plug, I wanted to encourage you to take a look at Baby's First Test. It has up-to-date resources on what states are offering, which I think is important, being up to date. It has good information for providers and also for families. So I encourage you to take a look at And how did we get here is sort of the next question. Why are we screening for what we're screening for? How did this major program come to be developed? And to understand that, I think you have to understand the history a little bit. So newborn screening, as I said, started back really in the 60s. Dr. Guthrie had a niece with PKU, and he also ended up developing the bacterial inhibition assay, which could detect elevated phenylalanine levels in dried blood spots. And for those of you familiar with PKU, if untreated, even for months to years, leads to ultimately irreversible intellectual disabilities. These children and adults were in homes for the rest of their life. But if you diagnosed it early and treated these children with a lower protein or phenylalanine-free diet, they were actually completely developmentally normal and had expectations for normal IQ. So it became a passion project. He started PKU screening of all newborns in Massachusetts, and it was such a success that it pretty quickly spread to the rest of the country. And that's how it became known as what was the PKU test back then, the only time you can call it PKU test. In the 1990s, it became the quote-unquote expanded newborn screening. As tandem mass spectrometry was utilized, they basically could screen for multiple different conditions at one time with one test, which was invaluable and expanded what was the newborn screening was capable of doing. And in 2000, universal hearing screening changed newborn screening a little bit by including a point of care test, which of course is separate from a dried blood spot, and from a public health programming and infrastructure point of view, really changed the setup of what we were doing for every newborn in the United States. But by 2002, there was a lot of variability in what was going on because this was happening state by state. And so in one state, you might be screened at birth for one condition, and in a neighboring state, right across the border, you might be screened for 29 or more conditions. And so this was a huge discrepancy and was setting up a lot of controversy in terms of what we were screening for, what we should be screening for, and how that should match for all babies born in this country. And in 2002, HRSA actually commissioned the American College of Medical Genetics to tackle this problem. So they kind of got everybody together, all major stakeholders in a room, and they had a massive screening tool, scoring tool, I should say, to go condition by condition and determine what was a disease that we should be finding at birth, treating from birth, that would do a lot of good for babies. And in 2005, they published their what's called Recommended Uniform Screen Panel, or the RUSP, and most people call it the RUSP nowadays. But it identified what they call 29 core conditions. Those are conditions that every baby in the United States should be screened for by their estimation, as well as 25 secondary targets. These are conditions basically that you are going to find just by looking for those 29 core conditions, and that maybe had some benefit worth reporting these 25 out as well, just in the identification. In 2008, the Newborn Screening Saves Lives Act was passed. This said a couple of things. What its purpose was to really standardize and support newborn screening, but not to mandate it. So that's an important distinction. It was really to help newborn screening find funding and build its infrastructure and standardize what it was doing, but it did not make newborn screening mandatory. It also created Baby's First Test, which is the Information Clearinghouse. And then in 2010, the Secretary's Advisory Committee, which was a product of the Newborn Screening Saves Lives Act, actually formally adopted those RUSP conditions and also determined that they were going to make all future decisions about what else should be added to the RUSP in the future. In the recent past couple years, the RUSP has grown and changed. It is now 34 conditions, up from 29. And MPS 1, XALD, which are starred there, were actually just added in the last year. So those are brand new. And New Steps was kind enough to provide me with this graphic, which is a little hard to read, but that's the state's screening for all 32 of the quote-unquote core disorders or the RUSP conditions. That doesn't include MPS 1 and XALD. But as you can see, there is some variability that still exists because this is unmandated screening. There are going to be discrepancies in how states are able to get the funding and the buy-in to add disorders, and so that takes time. But because of the Secretary's Advisory Committee and all of the great work of groups like New Steps and the regional genetic collaboratives like NIMAC, the states are at least aware of what the recommendations are and are all moving in the right direction towards adding the conditions which have been determined to give a major benefit to babies' lives. So the RUSP, what does it look like? It's kind of scary looking, but this is the core condition, RUSP, which you can find on HRSA's website. And then the secondary conditions are here on the right. They haven't changed since that original report. But the core conditions are the ones that are being updated. And they are further divided, all of these diseases, into categories. So the metabolic disorders are here in orange. The endocrine disorders are on the core panel in green. The hemoglobin disorders in blue. And then the other disorders in purple. And because I work in the metabolic side of things, I am going to sort of focus on the metabolic disorders, partly because I think these have the scariest names and people have less familiarity with them, but also because I would argue they benefit the most from timeliness, because some of these conditions really can cause complications and even death within just a few days of life. And so reacting quickly to abnormals and just buying into the importance of timeliness in general is going to benefit the children with metabolic disorders the most. So they are further divided, for your reference, sometimes this comes up, they're further divided into categories. So these are the organic acid conditions in dark blue, the fatty acid oxidation disorders boxed here in red, the amino acid disorders in light blue, and then the other disorders, the metabolic ones, are in green. And so you can see they make up the majority of the newborn screening panel, even though many of them are far more rare than things like congenital hypothyroidism, adrenal hyperplasia, and probably hearing loss. So what are metabolic diseases, or sometimes called the inborn errors of metabolism, or IEM? A lot of people in metabolic disease like to put up this graphic and say, metabolic disease is anything within this process, within these nodes could all be a disease point. But I think that often gives people just side eye because that's very confusing. It doesn't really tell you anything. So I like to simplify things and say metabolic diseases have to do with food. And it's of course a lot more complicated than that, but it's how you're taking food to make energy, and disturbances in that process are generally considered inborn errors of metabolism. And the more simplified way of looking at it is here. So you have your three forms of fuel: protein, carbohydrates, and fat. And the purpose, of taking them in is to make energy. And disorders within this are disorders of metabolism. Another important component of this pathophysiology, though, is the enzyme function. So if it requires enzymes to carry out metabolic function, it requires many enzymes to do that normally. And just as a visual here, to go from red star to yellow triangle requires various enzymes functioning normally. Disease occurs when one of these enzymes does not function normally, and that can cause problems for multiple reasons. Partially because you're going to end up with buildups. So in this case, if enzyme C isn't functioning properly, you're going to end up with a huge excess of this blue square. And if blue square happens to be a toxic metabolite, that's going to cause complications, things like ammonia. That said, there's also the problem of not enough of the things beyond enzyme C. So if you don't have a functioning enzyme C, you can't make enough of that orange pentagon or the yellow triangle you need to excrete. And if those are something you really need to function normally, that's also going to cause problems. In the case of MSUD, for example, like Logan from the first case, he had a disorder of branched chain amino acid metabolism. So his enzyme that is supposed to function to utilize those branched chain amino acids doesn't work properly. And so you end up with complications from the buildup of leucine, which is extremely toxic, and that leads to health problems associated with maple syrup urine disease. And to touch briefly on the genetics of this, not to go into too much detail, but I always try to jog people's memories by reminding them of Punnett squares. So most of the disorders on newborn screening are what's called autosomal recessive, with a few exceptions. But if you recall, that requires a carrier mother who's unaffected and a carrier father who is unaffected, and then their children will only have a 25% chance of having the disease. And the reason I point this out is because negative family history does not rule out an autosomal recessive disorder. Carriers are not affected. Other children may be perfectly healthy. And so just because a baby has an abnormal newborn screen but has a totally normal family history and has 5 brothers and sisters without a problem, it doesn't actually mean that this child is not potentially affected by the disorder, because 25% chance, other siblings may be healthy, and mom and dad would be healthy is my expectation. So just something to keep in mind. Wanted to go on to another case. As I said, these are real cases of babies, situations that have come up in practice. And Katie is a little 40-day-old baby who's been well and who has this following newborn screen. This is an example of one of the Maryland newborn screens. And I'll just kind of zoom in on the important part. But it says that her 40-day screen showed a galactose within normal limits and a reduced GALT. And this is on a repeat of a baby born at 36 weeks, normal diet with good weight gain. So my question for you to consider is, you call Katie's parents, she's doing well, they confirm that, she's actually breast milk feeding every 2 to 3 hours is no problem. So you must stop them immediately. Tell them stop breastfeeding because Katie has galactose. And the answer to this is false. And the reason is because this is a screening test, not a diagnostic test. So when you talk to families after an abnormal newborn screen, I want to highly encourage you not to tell them the child has a diagnosis with certainty, because that's really not always the case. Just to talk a little bit more, galactosemia is one of the disorders that children benefit from early intervention. And I'll talk about this, but galactosemia is a deficiency of that GALT enzyme, which was referenced in the newborn screen report. The GALT enzyme is responsible for processing galactose. Unfortunately, galactose is a toxic compound if it is allowed to build up, and so the symptoms can be quite severe and very quick in onset. They can have poor feeding, develop overwhelming E. coli sepsis, they can have bleeding, and they really can die within a couple of days of life. And the treatment is to remove galactose or breast milk regular formula from the diet, and that would be for treatment to save their lives. So these children absolutely would benefit from a timely newborn screen result. The way to visualize this a little bit, we take in food, and in particular, breast milk and regular formula contain galactose, which is broken down into galactose 1-phosphate, metabolized by the GALT enzyme. And in classic galactosemia, there is no functioning GALT enzyme. So the galactose 1-phosphate is allowed to build up with the overwhelming toxicity. And so we screen for this in babies. We look at the galactose, sometimes the galactose plus the galactose 1-phosphate, and we also look at that GALT enzyme and try to quantify whether that is a normal or not normal level. So to simplify this, because I think it gets a little confusing, we have the 2 analytes for galactosemia. Abnormal GALT is going to be a low GALT, because if a child has classic galactosemia, they have 0 functioning GALT enzyme. But an abnormal galactose screen is going to be a high level of galactose or galactose 1-phosphate, because we expect if you have no functioning GALT enzyme, this metabolite is going to start to build up and just at increasing levels. If you have an abnormal newborn screen for both of those things, so you have a low GALT and an elevated galactose, that is a critical result. That is potentially classic galactosemia, and I'd say immediate galactose restriction is warranted in this case. So that means no breastfeeding and no regular formula feeding, and only soy. It's still possible this is not classic galactosemia. It could be some kind of variant, but it's really worth treating this baby to keep them safe. If you have, however, a low GALT enzyme but a normal galactose, That could mean a couple of different things. If you have a baby collected at less than 24 hours, as happened with Logan, it's possible the galactose just hasn't had time to build up yet. But if you look at the other reasons, a false positive may cause a low GALT enzyme, and a baby with perfectly normal GALT enzyme. Also, galactosemia carriers may have low GALT enzyme. And so in cases like that, when you consider how old the baby is, the fact that she's doing well on breast milk, it's probably not a classic galactosemia picture, although I still, of course, recommend follow-up of the screen. But breastfeeding cessation is not always necessary or appropriate. This just is a very common question. I also get a lot of families or pediatricians that will talk about restricting mom's dairy intake in order to decrease her galactose, and that just will not help. That does not change the content of breast milk whatsoever to change mom's diet. If a baby has classic galactemia, they're not going to be able to breastfeed no matter what mom does. So just keep in mind, if you have an abnormal, it's always worth doing a little bit of reading if you have time about the disorders to have a kind of a better understanding before you talk to parents in order to increase their anxiety, and also to understand the importance of an abnormal newborn screen in this case for treatment and appropriate intervention, because it can really be life-saving in galactosemia. So another case, this is a 6-day-old male named Garth, and in this case, the pediatrician received a phone call from the state program at 5 o'clock. This is an example of a DC screen, and the bracketed part in red here is to draw your attention to the abnormality. But it's a C3 level of 12 with an abnormal ratio. There's a list here provided of what the possible causes for this kind of screen are, but it does say immediate referral to a metabolic specialist is warranted. The little background on Garth, he basically was born at 39 weeks, had some jaundice and phototherapy for a couple days, but went home on day of life 4 and was breastfeeding, formula feeding. And you give a call to mom. As I said, you're always trying to interpret these newborn screen results within their clinical context. And mom says he's still pretty yellow, and I think maybe he's been eating a little bit less. Maybe she's not totally sure. She's a first-time mom, for instance. So we call the metabolic specialist office, and they're closed for the day. So if you have an option to contact the oncology geneticist, would that be warranted in a case like ours? And before I even make you answer that question, I just wanted to draw attention to a great resource which exists for cases like this, and that is the ACMG ACT sheets. The American College of Medical Genetics created these ACT sheets. They're also the ones who were responsible for the rest, if you recall. But they exist for every analyte, including C3. They give a long description of what the disorders are, and they give you the following actions to take and kind of give you an urgency indicator. Not all of them say immediately underlined, so that's usually a first clue. They also have some clinical status questions, and poor feeding is in fact one of those. So in this case, I would say yes, an off-hours consult is absolutely warranted for Garth. Just to touch briefly on what the organic acid conditions are, there's a lot of variability in these diseases. There is a chronic form and an asymptomatic form of most of them, but the classic form is the one we're really trying to identify right away, because these children can go from feeding problems to really coma and death within a few days because of some toxic encephalopathies. And if you can identify them quickly, you can intervene and save their lives. So just something to keep in mind. These are important conditions to catch and respond to newborn screens appropriately. We screen for them by acylcarnitines. Those are going to be the odd number chains, so C3, C5, C5DC. And then the confirmatory testing, most importantly, is going to be your organic acids, but there can be some information gleaned by acylcarnitines, plasma amino acids, and genetic testing. The inborn errors of metabolism present in general in 3 ways, which I want to touch on. The neonatal kids are the ones that are going to be the most severe, and also these are, of course, the goal of newborn screening and newborn screening timeliness. But there are childhood and adulthood onset forms. The variability is probably based on residual enzyme activity, although it's not totally clear, but it can be hard to predict, even with genetic testing, who's going to be severe versus childhood onset versus adulthood onset. But the point here is that most children, even with the neonatal forms, are going to appear well at birth and even for the first day or so after birth. So keep those in mind. Children can really decompensate quickly with these conditions. And so even if you have a normal physical exam, if you have a critical abnormality for an organic acidemia, I would encourage you to take that seriously. The neonatal presentations of metabolic diseases in general, if you look at this list, you'll probably notice that they're often mistaken for infection and sepsis, and that consistently happens. So if you have an abnormal, a child with potential infection or sepsis concerns, and the newborn screen result is not back yet, I would highly encourage you to get it. That said, if you have a baby with possible sepsis and an abnormal newborn screen, they should still be worked up for sepsis. They could still have both. And odor is the exception for kind of giving you a clue. So in that kid with maple syrup urine disease, the maple syrup urine disease odor is very dramatic. It's very, very much like maple syrup. There's sweaty socks and IVA and mouthy odor and phenylketonuria or PKU. Another case is Amanda. She's 5-day-old, well female, little Bengals fan, and is a totally well child in the office. A little bit about her is she was born 37 weeks, and I'll go into this, but she had this abnormal fatty acid oxidation disorder screen for C14 and C14-1, and the interpretations of this is suggestive of possible VLCAD. So as I said, born at 37 weeks, had that episode of low blood sugar, but that resolved with a normal oral feed. But in the office, she looks good and is breastfeeding well, and it's a family you know really well. So in this case, would an immediate repeat just be appropriate to kind of rule out this VLCAD? Something to think about. But before I talk about the answer, I want to talk about what fatty acid oxidation disorders are like in general. So these are disorders of fatty acid beta oxidation, which is an important energy source for the brain, really responsible for energy of the heart and liver out of when you run out of glycogen stores. But to highlight, there's a variability in how these children may present, but sudden death is, of course, the most devastating and horrible complication from these conditions. So some children will appear well and will pass away from SIDS if they're not identified by newborn screening. And so that's what we, of course, want to avoid by diagnosing these kids by newborn screening. This is a graphic, not to be memorized, but just to highlight that variability, as I said. The green of the categories at the top means that the complication or clinical manifestation is possible or likely. Yellow means possible, and red means unlikely. But here you'll see yellow, you see sudden death is possible and something to be avoided, of course. MCAD deficiency, I just wanted to highlight briefly. That is actually the 5th most common disorder picked up by newborn screening, and that's of all the categories, fairly common. Before newborn screening, 30 to 50% of these children actually passed away during their first acute episode of MCAD. But if they're picked up by newborn screening and treated with simple fasting avoidance, we can avoid those kind of complications. So it's a success for newborn screening. But we also, or I shouldn't say we, but NIMAC has actually created what's called diagnostic guidelines for all the conditions by category on newborn screening, and this is what the VLCAD disorder guideline looks like. And if you take a look, actually, it explains that negative metabolites do not rule out this disorder. So to bring you back to the question at hand, actually in fatty acid oxidation disorders in general, newborn screens, repeat newborn screens are not appropriate because typically children will have normal biochemistry when they are well and at rest. So the newborn screen is really to test them at a time of great metabolic stress, which is the birth process. But after a couple of days, those metabolites may disappear. And so these children really benefit from specialist consultation to do some more in-depth testing. We screen through these also by acyl-carnitines, just like the organic aciduria. These are the even number chains, and the confirmatory testing, as I said, it may be normal when these children are well. So they definitely need genetic testing. And management of these disorders, not that you need to know how to manage them. But just to touch on this, because I think it's a question families often have: what does this mean? What does this diagnosis mean for management? The biggest piece of treating metabolic disease is avoiding catabolism, and so avoidance of fasting and careful inter-parent illness management, because of course these kids are not eating well when they're sick, as all kids who are sick kind of act, and also because fever increases how much you need to eat. We want to avoid these children not having enough food around and enough energy. Diet changes is also a very important piece, because in many cases we want to take out what these children can't metabolize, whether that be protein or specific amino acid or lactose, what have you. There are some vitamin supplements which can be, very important parts of treatment, or at least very helpful treatment in metabolic disease, but those are more common than the medications, which are pretty rare at this point for any of these diseases. And final case is a common question I get. It's a little Emily, who's 6-month-old little girl who was born in Central America and just came to the United States about a month ago. So essentially has an unremarkable birth history, but never had a newborn screen. So she looks good in the office, no developmental concerns, but what do you do next with a child like this? So you could continue to monitor, but not really do anything at this point. You could send a dried blood spot off to the newborn screen program just to check, or you could contact the state program for assistance. And I want to encourage and make a last plug here for contacting and having a relationship with your state newborn screening program if you can, because it's typically staffed by very excellent people who are very knowledgeable about newborn screening. In some cases, states won't do screens after 6 months for a little girl like Emily, and so there may be other options, or just to check that the child didn't already have a newborn screen done elsewhere. Good to contact them with questions as you have them in cases like that. And just to highlight the resources I touched on, the purpose of this presentation was not to make everyone an expert in how to manage and treat a child with metabolic disease, but just to provide you with some resources in the back of your mind to kind of respond to these screens as they arise, and to be able to react appropriately to them. So the act sheets are there, the baby's first test, as I said, the NIMAC diagnostic guidelines are available on the Wadsworth website, and the State Departments of Health, which are very Googleable in my experience. These are my references. And I wanted to provide my email address if you have questions about newborn screening, in particular metabolic screening. I'm happy to answer them. If I don't know the answer, I can typically figure out who to ask and provide some feedback on anything that comes up. I'm happy to take any questions.
Great, thank you so much, Sarah. That was fantastic. I think we all learned a lot. So for those of you with questions, just as a reminder, you have 2 ways to ask questions. You can type those into the question box, or you can raise your hand. So I encourage you to go ahead and do those 2 things. If you raise your hand, then I will unmute you so that you can, everyone can hear you and you can ask Sarah your question. Okay, we'll just give it a few minutes. There's no questions yet, but okay, we do have some questions. Okay, I have unmuted Mirade Vaitia. You can go ahead and ask your question. Okay, I guess we lost her. See if anybody else has their hand raised. Okay. Sally Umbro, do you have a question? Okay, we do have a question about whether the presentation would be made available and a copy of the resource reference list. Yes, the presentation will be made available and sent out to all of the attendees after. It will probably take a couple of weeks before it's up on our website, but we will send out an email to all of the attendees today and all the registrants letting you know when that is available and ready for you. Okay. Do we have a question? Kimberly Piper, I've muted you. Do you have a question, Kim? Unmuted you, rather.
Hi, this is Kim Piper. Can you hear me?
Yes, we can, Kim.
Oh, okay. No, I didn't have a question. I just had a comment. I thought this was a wonderful presentation, very comprehensive, and I think it really was a great summary. And I hope to be able to send this out to our hospital staff across the state that do newborn screening. So I was just writing to say thank you.
Great, thank you so much. Okay, we do have a question about whether there are any newborn screening education efforts for SQHCs and or primary care providers from the DC newborn screening program. So do you know of anything, Sarah, where their education is happening at federally qualified health centers in the DC area?
I don't, there's nothing specific. I'm always available as a resource to go meet people and do presentations for primary care offices. I've done that in the past. DC is also in the works for creating a all-day seminar about newborn screening for primary care providers in the district. I believe that's taking place in September, either the 14th or the 15th. So stay tuned for more information about that. You're welcome to email me as well directly, and I'm happy to talk more specifically about any resources or things that come up that I know about.
Great, thank you, Sarah. So not seeing any other questions today, we will go ahead and end the webinar, but I did want to let you know that there is another webinar scheduled, July 13th. We will hear from Allie Peaks, who's a nurse practitioner in Virginia, and she'll talk to us about the process for newborn screening at the hospital before the sample is received by the newborn screening program. Separate registration is required for each of these webinars in the series. If you go to the NIMAC website, which is listed there, you can register for those webinars and see when the entire schedule of webinars is out and available. We will also have the webinars posted there as the recordings become available. I do encourage you, after the webinar today, you'll receive an email as well as an evaluation question that will pop up at the completion of the webinar. It's very helpful to us to get that feedback, so please take a moment to do that. Thank you everyone for your time today, and thank you, Sarah, for an excellent presentation.
Thank you.